Hi everyone, this video is going to be about the ear. We'll be mainly focusing on its structure, the related functions, and its embryological origin. Ear can be divided into three parts for descriptive purposes. We have the external ear, the middle ear, and the inner ear. The external ear consists of the auricle and the external acoustic meatus. The auricle is made up of yellow elastic cartilage, which extends into the sinus tube of about 3 cm length, which is the external acoustic meatus. External acoustic meatus has skin with sebaceous glands, hair, and ceruminous glands. Ceruminous glands secrete wax. Wax protects the ear from insects, but in case of excess secretion, it might cause blocks. The auricle and the external acoustic meatus gets blood supply from the posterior auricular artery, the superficial temporal arteries, and the deep auricular artery, and they are innervated by the greater auricular nerve, auriculotemporal nerve, and partly by the vagus. The middle ear is a cavity in the temporal bone, which is filled with air. Its contents are going to be the three ossicles. You can keep them in mind using the mnemonic MISS. M for malleus, I for incus, and S for stapes. The malleus has an articulation surface for the incus and also has a handle by which it would be attached to the tympanic membrane. And stapes has a long limb with a bulbous end by which it would be attached to the head of the stapes. And stapes has a base or the footplate by which it would be attached to the oval window of the cochlea. So these three ossicles are going to be the contents of the middle ear. Now let's have a look at the middle ear. Now I've used this model, so I think it would be easy for you guys to understand. So this is going to be the medial wall of the middle ear, and the lateral wall of the middle ear is actually removed here. The lateral wall of the middle ear would be the tympanic membrane. Tympanic membrane is a fibrous, thin structure which has stratified squamous epithelium on the external surface and internally low columnar epithelium. And it also contains collagen fibers. So above the tympanic membrane we have the epitympanic recess. The medial wall of the middle ear or the tympanic cavity has this prominent structure, which is going to be the promontory. Promontory is caused due to the first turn of the cochlea. Cochlea is going to be an underlying structure. And we also have the oval window, which is going to be superior and behind the promontory. We also have the round window, which is going to be inferior and behind the promontory. We have a prominence for the facial canal. We have a prominence for the lateral semicircular canal. The oval window is closed by the footpiece of stapes, and the round window is closed by the secondary tympanic membrane. The roof is tegment tympani, which is a laminar bony projection from the petrous bone, and above that we have the temporal lobe of the brain in the middle cranial fossa. The floor is also a bony plate above the jugular fossa, and the tympanic branch of the glossopharyngeal nerve pierces it. The anterior wall has a smaller upper canal occupied by the tensor tympani muscle, which is supplied by the mandibular nerve. Tensor tympani muscle attaches to the handle of the malleus. When it contracts, it retracts the handle of the malleus and increases the curvature of the tympanic membrane and makes it more tense. The lower, larger canal is the eustachian tube, which slopes to the nasopharynx. It actually balances the air pressure on either sides of the tympanic membrane. It is usually closed, but it opens when we swallow, cough, or chew. The posterior wall has the auditors, which leads us to the mastoid antrum, and we have a pyramidal eminence, a bony pyramidal eminence from which the stapedius muscle arises. The stapedius muscle attaches to the neck of the stapes. It is a skeletal muscle supplied by the facial nerve. When the stapedius muscle paralyzes, we get an abnormal ability to hear more. The middle ear muscles contract during loud noises. When we hear loud noises, it actually protects the ear from high amplitude noises. It is called the tympanic reflex. It takes about 40 to 160 milliseconds, but as it has a time period of about 40 to 160 milliseconds, it might not protect us from gunshots or explosions or at the beginning of a thunder. The internal ear is buried within the petrous part of the temporal bone. We have the osseous labyrinth, which is marked in purple, and the membranous labyrinth, which is marked in blue. The osseous labyrinth is going to be the external structure, and within it we have the membranous labyrinth. The space between the osseous labyrinth and membranous labyrinth is filled by perilimb, and the space within the membranous labyrinth is filled by endolimb. The osseous labyrinth contains the cochlea, the vestibule, and the semicircular canals. The membranous labyrinth contains the cochlear duct, the utricle, the saccule, and the semicircular ducts. The cochlea is actually a spiral structure. It looks like a snail shell. We have an apical, conical bony stem called the modulus, and the tube rotates and spirals around it. At the top, at the apex, we have the helicotrema. And we also have the oval window, which is covered by the footpiece of stapes, and we have the round window, which is covered by the secondary tympanic membrane. Now let's have a look at the cross-section of the cochlea. We can see the modulus at the center, the cochlear nerve, and the helicotrema. We actually have three spaces in the cross-section of the cochlea. We have the scala vestibuli at the top, the scala media in the middle, and the scala tympani. Scala vestibuli and scala tympani contain perilimb, which are connected at the helicotrema, and scala media contains endolimb. And we have the organ of Corti here, which is going to be responsible for hearing, and the spiral ganglion, which contains the first neuron of the sensory pathway. We also have the racemose membrane, which separates the scala vestibuli from the scala media, and we have the basilar membrane, which is going to separate the scala media from the scala tympani. Here we have a picture of organ of Corti. It has a roof-like membrane, the tectorial membrane, and it has hair cells, which are going to be the receptors, and we have the basilar membrane at the base. We have a single row of inner hair cells and 3 rows of outer hair cells, which are embedded to the membrane. And we have nerve fibers or the afferents joined to the hair cells. The auricle funnels sound from the external environment into the external-acoustic meatus, which causes vibrations in the tympanic membrane, and then it causes vibrations in the ossicles. The ossicles are connected to each other by synovial joints. And the footpiece of stapes closes the oval window, and so the vibration is conducted to the perilimb, and from the perilimb to the endolimb. The endolimb vibrations in the endolimb causes the vibration of the basilar membrane. So the hair cells are going to bend. When the hair cells bend to one direction, it is going to cause the depolarization of the nerve, and it creates an action potential. And when hair cells bend to the opposite direction, it is going to cause hyperpolarization. In the cochlea, we have particular areas responsible for particular frequencies. When we hear a noise of a certain frequency, the corresponding area in the cochlea vibrates. But when we consider loudness, when we hear a loud noise, it creates more vibration and it makes more hair cells to bend. It increases the frequency of the action potential, and it is interpreted as a loud noise. The presence of some noises can actually mask off the presence of other sounds. This is called as the masking effect. We have 2 ears, and there is a small time interval of about microseconds between the time at which the sound arrives at the 2 ears. So there is a difference of loudness. We can use this to localize the environment and the things around us. Here we have the vestibular system, which is going to be responsible for balance. We have 3 semicircular canals, the anterior semicircular canal, which is anteriorly placed at 45 degrees, and the posterior semicircular canal, which is posteriorly placed at 45 degrees, and we have the lateral semicircular canal, which is going to be horizontal when we bend our head 30 degrees in the forward direction. and each of these semicircular canal, at one of their end it is going to be dilated, having the ampulla, and within the ampulla they have crista terminalis. This is a picture of crista terminalis. We have a gelatinous structure which is going to be the cupula, and we have hair bundles and the nerve fibers attached to it. And within this canal we have the endolimb. So when we start rotation, the fluid actually lags behind at the first hand. But when we start rotating at uniform velocity, the fluid also moves. But when we come to a halt at once, the fluid continuously moves and the cupula and hair bundles bend to the opposite direction, causing a feeling of reverse rotation. Though we have 3 semicircular canals, they actually open into the vestibule by 5 orifices. That is because the anterior semicircular canal and the posterior semicircular canal fuse to form a common canal. We have the utricle and the saccule in the vestibule. They have otolith organs. The otolith organ is in the floor of the utricle, so it is responsible for horizontal acceleration, and we have the otolith organ in one of the walls of saccule, so it is going to be responsible for vertical acceleration. Here we have a picture of the otolith organ. We have calcium crystals, calcium carbonate crystals, which are going to be denser, and we have hair cells, and they are going to be attached to nerve fibers. Actually, there are conditions in which, though there is no acceleration, there could be distortions due to gravity, and they help us in writing reflexes. Now let's look at the nerve conduction in hearing. We have the spiral ganglion cells from where the afferents start, and we have the dorsal cochlear nucleus and the ventral cochlear nucleus where the afferents end, and we have the inferior colliculus which are responsible for the auditory reflexes, and we have the medial geniculate body which relays afferents to the primary auditory cortex. The primary auditory cortex is in the superior temporal gyrus. The central connections are bilateral at all levels, and the afferents are also sent to the reticular system and the cerebellum. Different parts of the ear has different embryological origin. The auricle is derived from the 6 mesenchymal hillocks along the first and second pharyngeal arches. The external acoustic meatus is derived from the first pharyngeal cleft. The tympanic membrane has an ectodermal epithelial lining, an intermediate mesenchyme, and an endodermal epithelial lining arising from the first pharyngeal pouch. The tympanic cavity and the eustachian tube has an epithelial lining of endodermal origin and are derived from the first pharyngeal pouch. The malleus and incus are derived from the first pharyngeal arch, while stapes is derived from the second pharyngeal arch. The internal ear arises from the aortic vesicle. The ventral part of the aortic vesicle forming the saccule and the cochlear duct. The dorsal part of the aortic vesicle forming the endolymphatic duct, the utricle, and the semicircular canals. We may come across various clinical conditions which are due to abnormalities in the formations, the embryological formations. There could be congenital hearing loss due to defects in the formations of the eardrum or the ossicles, or maybe the nerve ganglia. External ear defects is also a common defect or a common clinical condition we come across. As neural crest cells contribute to the formation of external ear and various other important structures, external ear defects may indicate the presence of other mild or severe clinical complications. Tests for hearing is a common question in exams, and we'll be looking at Weber's test and Wien's test. In Wien's test, we first strike the tuning fork and place it on the mastoid process. We ask the patient whether he is able to hear. If not, he might be having nerve deafness for the particular frequency. If he is able to hear, we ask him to inform when the sound disappears. At the point where the sound disappears, we take the tuning fork and place it at the external acoustic meatus. At this occasion, if he is able to hear the noise again, the sound again, he is normal. If not so, he might be having conduction deafness. In Weber's test, we'll be striking the tuning fork and placing its base on the vertex or the center of the forehead. We ask the person whether the hearing of the sound at both ears is equal. If the sound is louder in one of the ears, it means the louder ear might be having conduction deafness, or the other ear might be having nerve deafness. Hope this video was useful. Please like the video and please do subscribe our channel. Thanks for watching.